Welcome to the Deep Dive, where we pull out the most critical, high-yield info from the most authoritative sources in medicine. Today, we are immersing ourselves in, really, the definitive guide for pediatric infections, Nelson's Pediatric Antimicrobial Therapy 24th edition. Our mission is simple, to give you a shortcut. We're going to distill the essential updates from this 2018 edition, focusing on drug selection, dosing, and of course, antibiotic resistance. We want to get to the clinical takeaways you can actually use.
And it's such a necessary deep dive. I mean, the world of pediatric infectious disease is just constantly changing. This edition, when it came out, it brought in some major breakthroughs. We're talking new drugs for old enemies like MRSA and, much-needed algorithms for handling the growing threat of multi-drug resistant gram-negatives.
Absolutely. So let's start with maybe the most fundamental challenge in PEDS. Dosing. It's never simple, is it? We're dealing with rapidly developing bodies. When the guidelines are trying to determine a dose, what are the key variables they're trying to balance?
Right. It really boils down to a handful of critical factors. It's all a risk-benefit equation. We're not just trying to kill the bug. First, you've got pathogen susceptibilities, and those are always changing, always regional. Second, how well does the drug even get to the site of infection? That's a huge pharmacokinetic hurdle. Then there's toxicity, of course. And, something we're thinking about more and more is the collateral damage to the child's microbiome.
That's a huge one. And that brings us to pharmacodynamics. We all learn about the MIC, the minimum inhibitory concentration, but success is so much more than just hitting that number. How did the guidelines sort of mathematically describe getting enough drug exposure?
Yeah, we use three main mathematical models or ratios to predict if we're going to be successful. It's all about quantifying the contact time between the antibiotic and the bacteria. So for time-dependent drugs like your beta-lactams, we focus on the percent T over MIC.
So the percentage of time the drug level stays above that minimum concentration.
Exactly. You need that long, sustained contact. Then for concentration-dependent drugs like aminoglycosides, it's all about the Cmax, the P concentration. They need that big initial punch.
Okay.
But the most versatile measure really is the AUC to MIC ratio.
Right, the area under the curve compared to the MIC.
Right. And that ratio is so powerful because it lets us compare two totally different antibiotics, different absorption, different MICs, and see which one gives you superior overall exposure to the bacteria.
That makes so much sense. You're standardizing the whole measure.
Yeah.
But here's the reality check, right?
Yeah.
For kids, we're often working with extrapolated data. Tell us about this adult-to-child bridge.
It's a necessary compromise, really. We just don't have enough pediatric studies with enough treatment failures to calculate a true dose breakpoint for children. So we use pharmacokinetic modeling. We take the successful exposure value from adult, that AUC to MIC ratio that works, and then we basically reverse engineer the pediatric dose in milligram per kg that will reliably get the child to that same exposure level. It's a foundational concept.
Okay, let's pivot to the big battles. Resistance. We have to
Yeah.
talk about multi-drug resistant gram-negative bacilli, the MDR GMBs. This is a global headache. Who are the key players here, and why are they so tough to treat in kids?
The key players are bugs like Pseudomonas, Acinetobacter, and critically, ESBL-producing E. coli, which we're seeing more and more outside the hospital.
Yeah.
And they're so difficult because of their defense mechanisms. They have enzymes that just chew up our antibiotics and efflux pumps that literally spit the drug right back out.
So the Nelson text proposes this tiered approach for empiric therapy. Can you walk us through the concept behind those tiers?
The tiers are all about managing that risk-benefit ratio. You always start as narrow and as safe as possible. So tier 1 might be ampicillin if you think you've got a simple community E. coli. But if you suspect resistance, you have to climb that ladder. You move up through, say, third-gen cephalosporins, then maybe carbapenems in tier 3.
And the higher you go, the more toxicity you're accepting.
Exactly. Tier 6, for instance, has agents like colistin. That's a highly toxic drug, and it's basically reserved for when nothing else works. The tiers force you to justify every step up.
Right. And looking ahead, the 2018 edition mentions some newer agents in tier 5, like ceftazidime-abactam.
Yes, and those combination drugs are the future. They're specifically designed to overcome those enzymes, like the ESBLs. They represent where we're headed for these really tough bugs.
Okay, let's switch gears to the other huge threat, MRSA. This edition brought a true game changer, ceftaroline. Why was this such a big deal for pediatrics?
Ceftaroline was a massive update, approved in 2016 for kids over 2 months. It's the very first cephalosporin that is active against MRSA. For a clinician, this is a huge win. The text even says you should consider it preferred over vancomycin for things like complicated MRSA skin infections or community-acquired MRSA pneumonia.
And the practical advantage there is just enormous, right? Why is that?
because it's a beta-lactam. Unlike vancomycin, you don't need to check drug levels, and you don't need to do intensive renal monitoring. It's a high-efficacy, low-monitoring option for MRSA. It just simplifies everything.
We should also touch on daptomycin here. It's another powerful tool, but it comes with a huge, very specific warning.
A critical one, daptomycin is highly bactericidal, great for skin infections,
Yeah.
but the warning is that you can never use it for pneumonia. Pulmonary surfactant in the lungs completely inactivates the drug, making it useless right where you need it.
Okay.
And there's also a label warning for infants under 1 year based on some animal data.
An excellent point to highlight. Okay, moving on from bacteria, let's talk about antifungals. We can start with the old workhorse, amphotericin B. How has the standard of care changed there?
It's shifted dramatically, all because of safety. The old formulation, AMBD, is effective, but it's just notorious for infusion reactions, fever, chills, and pretty significant nephrotoxicity. So now the costlier but much, much better tolerated lipid formulations are preferred. You get the same efficacy, but with way less risk of kidney damage.
That makes perfect sense. Now, with the azoles, dosing nuance is everything. For fluconazole, the text makes a big point about loading doses.
It does, and that loading dose can be the difference between success and failure. The standard maintenance dose is 12 milligrams per kilogram per day. But for infants, you often need a 25 milligrams per kilogram load on day 1. And think about a child on ECMO.
Right, the circuit basically acts like a giant sponge for the drug.
Exactly. It increases the volume of distribution. So for those kids, you need an even higher load, up to 35 milligrams per kilogram, just to get to a therapeutic level.
That is a life-saving detail. What about voriconazole? It's the go-to for invasive aspergillosis. Why do kids need a different starting dose, and what's its unique long-term risk?
It's all about metabolism. Kids metabolize it much more quickly and linearly than adults do, so they need a higher starting dose, 9 milligrams per kilogram per dose, just to keep up. As for toxicity, the big long-term concern is phototoxicity. It can make patients very sun-sensitive, and over years of therapy, it's been rarely linked to cutaneous squamous cell carcinoma.
Wow. Okay, and finally, the echinocandins. What's the basis for their amazing safety profile?
It's their mechanism. They inhibit an enzyme, beta-1,3-glucan synthase, that's essential for the fungal cell wall, but completely absent in human cells. So they're incredibly specific. They aren't metabolized through the CYP system, so fewer drug interactions, and no need for renal dose adjustments. They're great for invasive candidiasis, but you have to remember their limits. Poor penetration into the CSF and urine.
Let's talk about special populations, starting with newborns, who are just the toughest to dose.
This is where we have to admit our data is limited. A lot of neonatal dosing is still extrapolated from older kids and adults. It doesn't fully account for ontogeny, those rapid developmental changes in babies' metabolism.
Is there a good practical example of a specific neonatal recommendation?
A great one is fluconazole prophylaxis. For high-risk neonates, specifically those under 1,000 grams at birth. In a nursery with a high rate of candidiasis, the recommendation is 3 to 6 milligrams per kilogram, twice weekly for 6 weeks. That's a very direct, actionable guideline.
And on the other end of the scale, for obese children, what's the recommendation for surgical prophylaxis?
For cephalosporins, like cefazolin, you dose based on total body weight, or TBW, all the way up to the maximum adult dose. It's a pragmatic way to make sure you get enough drug into that expanded fatty tissue to be effective at the surgical site.
I want to talk about a huge stewardship win, the move to oral step-down therapy for serious infections.
This is such a critical principle. For things like osteomyelitis or severe cellulitis, once the child is clinically stable, usually in 2 to 4 days, you can switch from IV to oral therapy. And the key is using high-dose oral beta-lactams. We're talking 2 to 3 times the normal dose, like amoxicillin at 75 to 100 milligrams per kilograms per day. This high dose is what gives you the tissue exposure you need to wipe out the remaining bugs.
And some drugs are just perfect for this because of their bioavailability.
Exactly. Clindamycin, the fluoroquinolones, linezolid, Bactrim, and tronidazole, their oral versions give you almost identical exposure to the IV forms, making that step down seamless.
Okay, let's finish with the absolute most crucial safety considerations. The ceftriaxone warning is, as you said, non-negotiable.
It is a paramount safety alert. Ceftriaxone is strictly contraindicated in any neonate younger than 28 days if they are getting any kind of parenteral calcium. The risk is fatal precipitation of ceftriaxone calcium in their lungs and blood. For newborns, the safer choice is always cefotaxime.
And when monitoring aminoglycosides like gentamicin, what's the balance we're looking for with peaks and troughs?
You're balancing efficacy versus toxicity. You check the peak to make sure you hit a high enough concentration to be effective.
Yeah.
You check the trough to watch for toxicity. An elevated trough, say over 2 for gentamicin, is a big warning sign that the drug is accumulating and toxicity might be coming.
Finally, the fluoroquinolones, or FQs. Is the old fear about cartilage damage still a major restriction in practice?
The clinical reality has definitely shifted. While the toxicity was seen in animals, the text clarified that as of 2017, FQ attributable joint toxicity has not actually been documented in kids when used for its approved indications. That said, we still restrict them, wisely, to situations with high resistance or where you really need a good oral option.
And one last quick note on doxycycline and teeth staining.
Right, the risk is real, it's dose-related up to age 8. But the guidelines also note that a single short course of doxy probably won't cause staining. So the benefit of using it for serious diseases like Lyme or Rocky Mountain spotted fever almost always outweighs that risk, regardless of the child's age.
That was an incredible synthesis. We covered dosing mechanics, strategies for MRSA and MDR-GMB, and some really critical safety alerts.
And just remember the core principle here. The book gives you the framework, but your knowledge is only truly valuable when you pair it with real-time local data. Always, always consult your local antibiogram.
That's the perfect final thought. To help all this sink in for you, here is a quick review question based on what we just covered. A 6-month-old infant is diagnosed with a complicated MRSA skin and soft tissue infection that needs IV therapy. Based on the 2018 Nelson's recommendations, what is the preferred IV antimicrobial agent and what specific advantage does it offer over high-dose vancomycin for this baby?